Hi, this is Erin Phillips, and my wicked problem is unintentional harm caused by childhood obesity prevention and treatment interventions. And this presentation is kind of my update on where I am at this point, talking about and researching my wicked problem. So first, an overview of the problem. What is it exactly? So essentially, it's the idea that by focusing on health as a primary indicator, by focusing on weight as a primary indicator of health, we are doing harm to the public and to our patients. So a little bit more about what I mean by that. So we'll break it up into two kind of areas in which this happens. First is in schools and communities with obesity prevention initiatives. So in this area, in schools and communities, when we initiate obesity prevention initiatives, if the focus in these initiatives is on obesity and weight, we run the risk of perpetuating the idea that fat bodies are bad and thin bodies are good, which worsens bullying, weight bias, and weight stigma. And with public health interventions like these that were on billboards and in magazines, it's no wonder that these types of interventions increase stigma and cause harm. Next is in healthcare. And so when we encourage weight loss among children, adolescents, and families, either weight loss or encouraging them to stop or slow weight gain, we risk having those families and kids feel like they're failing and then not return for follow-up. And then we lose them and they feel like they're failing. The majority of the references I have there are talking about how the majority of people who try to lose weight ultimately fail. And so it's no wonder that that obesity intervention programs have such high dropout rates. Next potential harm that can be caused by these interventions is because of weight cycling and yo-yo dieting. So the majority of efforts, weight loss efforts, result in weight gain. Later on, they might lose weight, but then they'll gain weight later. We call that weight cycling, which, as these references show, cause more harm than if that individual had just stayed at the same weight to begin with and not tried to lose weight. Next, families can misinterpret messages. We might be encouraging these patients and families to lose weight in a healthy way, but they might misinterpret that and just focus on gotta lose weight and do unhealthy things like skipping meals or other unhealthy behaviors. Next, we run the risk of decreasing body satisfaction in our patients and families. And decreased body satisfaction is associated with increased weight gain over time among adolescents. Next, we obviously increase the risk of eating disorders by encouraging families to really focus on weight and losing weight. So I really liked this quote to kind of sum up why this is a problem. Whoops. And it's by Nan Failer, who was the Deputy Health Commissioner of the City of Philadelphia. So some people believe that stigma is helpful in motivating weight loss, that making it uncomfortable or undesirable to be overweight will somehow help people lose weight. But a large and growing body of research disputes this. Studies show that youth routinely cope with feeling bad about their weight by trying to lose weight in harmful ways, like fasting, diet pills, vomiting, and chronic dieting, leading to binge eating and avoidance of physical activity, all unhealthy behaviors that can actually impede weight loss and reinforce weight gain. Confronting stigma, bullying, and weight bias needs to go hand in hand with efforts to reduce the prevalence of obesity nationwide. So that's an overview of the problem. Next, what has been done? So first, there has been an increased focus on or increased implementation of weight-neutral interventions. That's things like health at every size, where the focus is on behaviors in all aspects of health, including mental health, and not weight. The Association for Size, Diversity, and Health has done a lot of research and advocacy in this area. Next is changing health promotion in schools. This could be a focus on behaviors and not weight. Interventions like the 5210 program from Maine has also been used at my pediatric health care facility where I work, and that's focusing on 5 servings of fruits and vegetables every day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 soda and sugary beverages. Another way of addressing this problem in schools is by implementing some family life and health curriculum, or different curriculum into the family life education, which is the puberty and sexuality education in around 4th and 6th grades. An example of this is the Healthy Bodies curriculum by Kathy Cater, who worked for many years as an eating disorder therapist and realized that the focus on obesity prevention in schools was causing more kids to have eating disorders. And next, the next way to decrease this problem is by increasing and implementing weight stigma training in healthcare communities with doctors, dietitians, nurses, and other healthcare professionals. The Red Center for Food Policy and Obesity, which we have here, over here, has a ton of resources for educating oneself and others on the effects of weight bias and stigma and how to decrease that. So here are the solutions I came up with, or the options I came up with for policy solutions. First would be a policy for all school-based health interventions that would state that interventions and or obesity prevention messages must follow these certain guidelines. First, they should be referred to as health promotion rather than obesity prevention, so that the focus is on health and not on weight. They should promote self-esteem, body satisfaction, and respect for body diversity. Body diversity meaning that bodies come in all shapes and sizes, and there is no one ideal body. And that the focus should be on evidence-based modifiable behaviors, like sugary beverages, like the 5210 behaviors I mentioned on the last slide. Another idea would be a school-based family life curriculum. My idea was to implement the Healthy Bodies curriculum that I mentioned on the last slide as a part of that family life 4th through 6th grade puberty and sexuality education in public schools. Another idea would be a health clinic-based weight-neutral intervention. This would be a health promotion intervention at a pediatric primary care health clinic. So when children are found, so doctors are required to screen for childhood obesity, and then intervene. So the idea would be that those children who have a BMI above the 95th percentile and are classified as obese would be referred to this type of intervention instead of the traditional weight-based obesity intervention. So it would be implemented by health at every size dietitians and community health workers, and would focus on health behaviors, physical activity, intake of sugar-sweetened beverages, teasing, and screen time. It would also promote self-esteem and positive body image, and would also involve parents with education and empowering those parents to make changes. Finally, my last idea for a policy solution is weight bias training for healthcare professionals. We would train healthcare professionals on the effects of weight bias in healthcare and how to decrease those, and it would be presented at a local public health department and would be optional to attend. So here is my decision-making Pew matrix. You can see the criteria I included are effectiveness, political and cultural feasibility, cost, and then overall implementation feasibility. And I weighted effectiveness as the highest, the most important, and cost as the least important. And as you can see, the Healthy Bodies curriculum won. So that will be I think, the intervention that I will be working on implementing. So here are my references, and I'm looking forward to hearing feedback and working on implementing my solution to the wicked problem. Thanks.